Hello, everyone. Welcome to my show. Autumn is here. We have an interesting show today. We're going to speak to Dr. Jasmine Travers Altizer, and she's going to talk to us about aging, about nursing homes, about different research projects that she's done. So please welcome her to the show. Welcome, Jasmine. How are you?
I'm good. Thank you. Thank you for having me here, Francine.
Well, thank you for taking the time to give us some information today. As you know, my podcast, we talk about caregiving. We talk about people who are getting older and seniors and how to better care for them and have a better quality of life, and give some information and some research and some different things that will help people and help caregivers and help family members to get involved with their aging adults. So please tell me, let's start off with telling me just a little bit about yourself.
Yeah, thank you. So I'm Jasmine Travers Altizer. I am an assistant professor at NYU in the College of Nursing. I'm a nurse by background, an adult gerontological nurse practitioner, and also a health services researcher. A lot of my work focuses in long-term care settings, across settings. So in the home and community, but also in the nursing home space and assisted living. And really what my program research focuses on is supporting older adults to live in the communities that they want to live in for as long as they should be able to live in those communities. So whether it's them being able to age in place in their own homes for as long as possible, or for them to be able to live in the nursing homes and live there as if that were their home with the best quality of care. So I spent a lot of time thinking about quality of care, outcomes of care that people experience, cost of care, and then also looking to workforce and recognizing the workforce and caregivers are very much a big part of the care that older adults receive across these settings, and the conditions that the workforce experiences and the training that they have or don't have. And then I do look at all these things with an equity lens.
Oh, okay. So let's talk a little bit about that. Like, what have you found in doing some research in nursing homes and seeing the care that was given there, and have you spoken to the actual residents of the nursing home?
Yeah. So my work is kind of uses a lot of different methods. As a health services researcher, I engage with a lot of big data. So I've been fortunate to be able to look at these issues from a national perspective and understanding them, but then also bridging them together by being into the nursing homes and seeing what's going on. So from the data, what we see is that quality of care is largely can be largely disparate in nursing homes, and this is based off of the proportion of residents who may be Black within a nursing home, or the proportion of residents who have Medicaid in a nursing home. We see poor quality of care to those residents in those kinds of nursing homes. So, for example, worse pressure ulcers, falls, restraints. People who receive antipsychotic medications inappropriately are seen in those nursing homes, and then poor staffing are seen in those nursing homes as well. And why is that? In many cases, if you have a high proportion of residents who are Medicaid doesn't cover the cost of care that a resident receives within that nursing home. So the nursing home may have to really decide on what they are using that money to go towards, and sometimes it's not. They're not able to put that money towards staffing or additional improvements that would support the quality of care for residents in a nursing home. We also see disparities in nursing homes that are for-profit versus not-for-profit. Those who are for-profit receive worse quality care as well, and also decreased staffing. And when it comes to for-profit, a lot of times these nursing homes are really focused on returning funds to their stakeholders and not necessarily using a lot of those extra funds to support quality efforts such as staffing and resident care.
Well, that's very interesting, because we do know, and I've gone to different nursing homes and different things like that. I've experienced some stuff, and we do know the quality of care. There leaves much to be desired. I never understood And I never thought about it. I thought that when you have Medicaid, it covers everything, and that they should get the best care available. And now you're giving something to my attention, that the amount of money, I guess, whatever they get from Medicare, they have to decide what they're going to use that for. Because sometimes, yes, I do see that some people are not getting all the attention, and yes, they do get bed sores, and they're not turned all the time, and there are certain things that are happening. Um, I've been to one where they said they didn't have guardrails on the bed, and it was like, why? And they said, well, it's not allowed, and that didn't make sense to me. So now I'm thinking, you're saying that people who have Medicaid, I'm thinking they're covered, but it's up to the facility to decide how they're going to use that money. Am I correct?
Yes, and there's two sides of it. So, on the individual person side, when we think about long-term care and long-term care benefits, there is no um, federal long-term care benefit for long-term care. Because Medicare, that only covers short-term needs, that covers hospitalizations or skilled nursing care. Um, and we don't have, and then there's long-term care insurance if people have subscribed to that at a decent age, or for those who are private pay, those are people who are very wealthy and can afford the cost of nursing home care. But outside of that, the only way to be able to pay for nursing home care is by impoverishing yourself or those who are already impoverished so that you qualify for Medicaid, and then Medicaid will cover your nursing home stay. So from the individual standpoint, yes, if I do have Medicaid, I will be able to pay for my nursing home stay, and that I won't be responsible for that. So yes, that is covered. But on the other side of it, when we look at the system and facility level side, they actually, yes, that covers that care, but Medicaid for them doesn't pay a lot when it comes to reimbursement. They're going to get the most bang for the buck from Medicare, a little, like more than Medicaid, and then the most is going to be private pay because they can charge that full amount. So that's why not only in nursing homes, but even in primary care offices and clinics, they actually don't get that the whole amount that they would get from private insurances when it comes to Medicaid and even Medicare. So they try not to have as many patients who have those types of insurance, and then have more people who have the other insurances are paying for private pay, because then that will bring in more reimbursement so that they can cover their costs. So that's how nursing homes kind of do it. They balance the amount of people who are paying from different sources so that they can kind of make up the difference. Not to say that Medicaid doesn't help, because that's better than someone who's not paying at all, and that is still bringing in funds, but that is lower funds that their nursing home is receiving. If they have a higher proportion, those who are Medicaid versus those who are paying from other sources, it does eat into their overall revenue.
Okay, okay. Yeah, no, it's great that, you're able to have something if you have nothing, but it just opens up this whole window of, now I'm understanding like what's actually going on. So let me ask you something. Does a city or state have certain things that you have to do? Like, certain care that they have to do regardless if they have Medicaid or whatever. If you are a nursing home and you have opened in the state or the city or whatever, do they have certain care and certain treatments that have to be taken care of?
Yeah, and because Medicaid is typically managed on the state level, the amount that reimbursement the amount of reimbursement can change versus the state as well. So that's something to also know. But just to your question, there are requirements. If you are a nursing home that receives Medicare and Medicaid, you do have requirements that you have to meet, baseline requirements. You get inspected every 12 to 15 months to make sure that you are meeting specific requirements, specific safety level checks, staffing level checks, and things like that. But we also have seen nursing homes who kind of, they say, game the system. If they know the inspector's going to be coming in around that time, they start to staff up, and make things look a lot better than they really are. So that's one side of it. But then also another side, though, there are some states that are requiring a certain amount of your funds that you receive go to resident care and staffing, because some of the issues is that there's this kind of tension between nursing homes saying, we don't get enough money, we don't get enough reimbursement. And then the other side, the state and federal, saying you're not using the money in the right way, especially for profit. And it's like, well, where is all the money going? So that's the question. Where's the money going? We're trying to figure out and make better systems to actually see what are you doing with the money. But yes, there are some states, New Jersey, for example, who will say, a certain percentage of money, I don't remember what New Jersey's is, whether it's like 70% or 80% of funds have to go, the funds that you receive from Medicare and Medicaid have to go back to the resident care and have to go back to staffing. So some states are doing that, which that's actually a study that we have where we're looking at a program that came out during the pandemic. It's called the Paycheck Protection Program. And this was a loan program. It was one of the programs that came out to support businesses and facilities to keep their staff on the payroll. Now, this was one for small businesses, but interestingly enough, pretty much all nursing homes qualify as small businesses. So they're eligible to apply for this loan, and they would get this loan forgiven if 60% of the funds that they received went towards keeping their staff on the payroll. So it's kind of this natural experiment in a way to see, all right, if we could advocate for people, for nursing homes to put a certain amount of money towards staffing and see what actually happened as far as outcomes and such, maybe we can, use these data to really advocate for us to have all states put a certain amount of funds towards staffing, because that's just also been a thing. We've been calling for it, but not all states do it. Only a few states do it, where so far we are seeing better hours as far as nursing homes receive these loans, experience better nursing assistant hours after receiving those loans. And then we also see better outcomes with the residents. We're seeing decreased mortality and decreased emergency visits right now. So this is something that has been really striking for us, and saying that such a program and just such directed guidance as far as where money should go is supportive of resident care and staffing.
Okay. So during this research, and what is coming out of it is you were trying to see, you also was trying to see how they could have better quality care in nursing homes, or how to keep them home as long as possible. Is that's part of it?
So not this particular research study. That kind of answered your question as far as, what are cities and states doing about where the money is going. But as far as keeping people at home, so that's another research study that we're doing, where we're trying to, a large percentage of folks, over 2/3 of people, want to stay in their homes for as long as possible. But hundreds of thousands of people end up going into nursing homes unnecessarily, where the care that they're receiving in nursing homes, they could have received it in their home and in the community. So right now, what we're doing is we're trying to understand what are the unmet needs that older adults experience in the community setting that drive these avoidable and unnecessary nursing home placements. And what we did, what we've done to start to generate these data is we've gone to nursing homes themselves, and kind of worked it the other way, where we're talking to nursing home residents and their family members and nursing home staff. These are people who were deemed eligible to stay at home, and asking them, what did they have in the home setting that drove this nursing home placement? So they've been sharing different things with us, And we've been also speaking to aging experts within the communities as well. And particularly, we've been focused on Black and Latino people and people living with dementia because there's not enough attention spent to this group, but also understanding that there's a lot of resource gaps and support gaps in these communities. So that's the study that we're doing, where we've collected all this data on unmet needs and then have created a tool that we want to be able to go back and use in the community to use in different settings like hospitals or through social workers so that they can start to have conversations with older adults and their family members about this different unmet needs that they have so that they can connect them to the supports and services based off of what they said that they don't have. And then after subsequently, that could hopefully avoid a nursing home placement. And the reason why we did this is that because one might say, "Oh, you could just ask someone, what don't you have that you need?" But people don't know what they don't know. So being able to have a tool where it's built from data that people have found along the way, now in a nursing home and looking back and saying, "Oh, this is what I didn't have," that really helps to drive thinking of, "Oh, this is what I don't have," and this has been shown that these are things that commonly lead to nursing home placements.
What are some of the research gaps? What are some of the things between the disparities between different?
Yeah, so some of the research gaps, like a big research gap was, which is very interesting, has to do. So when we think about dementia, right? There's the dementia that is the medical side of it, but then there's the social context and cultural context side of it too, where when we think about managing dementia, and like your neighborhoods are so important. Your family is so important. We know caregivers are decreasing as far as their proximity, as far as their availability. They're living farther. They're living out. They're working outside of the home and more hours, and the kids and more demand. So they're not as home and proximal to the family member as far as the older adult and person living with dementia as they used to be. So not having that family really kind of changes the ways in which and that people that they know changes the dynamics of a person living with dementia. But then also something that's when we think about context and social context and that neighborhood and things. I think about gentrification, right? And we think about just like the harms of gentrification, but then even for the older adult and the person living with dementia, now when you have less people who look like you, who you've grown with, right? Because we're moving people out and all these new people, and you think about the person living with dementia, those support systems that you've had, just that neighborhood feel that you had before, that changes things too. It makes it harder for that person to live in their house. They might have more just different behaviors or different symptoms, and that if unfamiliarity with your surroundings, which may lead to someone to say, "Hey, I have to put them into a nursing home because they can no longer, really just be safe in this neighborhood, yeah, and comfortable." So things like that, where you're like, wow, as we talk about gentrification, but not even seeing how that even changes, the dynamics that one person who was so used to, especially a person who was living with dementia, and really like that familiarity is so important to them.
Yeah, yeah, that's interesting. I live where I lived all my life, and I've seen the changes, and the neighborhood is different. It is different, and the people and the relationship with the people is different. So I can see if you're older and you're feeling a little uncomfortable and not as safe, not because someone is doing something bad, because your people and who you've grown up with, and that this person would look out for you, or this person had
Exactly.
resource for you, or this person, you can send this person to the store, or you can things you're
Exactly.
comfortable with, and now you don't know these people, and it's yeah,
Exactly.
yeah, yeah.
Exactly. You have so many more, you had so many more supports when thinking about the family, it wasn't just you, it was the whole neighborhood that looked after, and now that has decreased. So that has also made it harder. So little things like that we don't even think about how it has changed, and the disparities that we see in some communities versus other communities.
Yeah, it's very interesting that as far as being a caregiver and a family member, there's things that we need to be alert about and recognize. So what are some of the things that you would say that we should be knowledgeable about ahead of time before, this happens, before somebody has dementia or stuff like that, or the information that we should get? What should we know about or look for in our loved one, in our aging loved one?
Yeah, no, definitely. I think just to kind of thinking about dementia, if there are things that, if you just notice different mental health changes, someone saying, something looks different, or not sure who you are, or they get lost, or they start to put things in the microwave that shouldn't be in the microwave. Just things that seem just a little off, and you're like, oh, that's nothing. Just start to take note of that, and then just bring it up to a primary care provider, or a gerontologist, or someone who can um, just probably do an assessment to see what's going on with the older adult loved one. Maybe it could just be, just random, could be a fever, and they were sick, and that's why there could be confusion, or it could be something that's leading to dementia. But I wouldn't just kind of shove it under the rug. Just kind of like really start to note it down, even maybe even keeping a journal, so you can say more definitively what happened. Because sometimes you're like, oh yeah, you start to think back, and you're like, oh yeah, I remember this happened, and that happened, and that happened, and before in 1 minute, you just kind of like just shoved it under the rug, and then you're like, oh wow. So really, just taking note of those things and then bringing them up would be important, and then just kind of thinking about the resources. I would be a bit more proactive about engaging with a social worker, or engaging with your area's agency on aging, to identify what supports are available to us, because that's the biggest thing that family caregivers have shared, is that they don't know about the resources and the supports. And when it comes to spouses more than children, spouses are less likely to use supportive services, and they're more likely to get information from healthcare providers. So healthcare providers really need to make sure that they are, giving that information, or we're asking that information from them. But but those are some of the main things that I would say as far as approaches for a loved one. But definitely seek supports. There's supports out there. They could be more limited in different areas, but I wouldn't want for people to just feel like there's nothing out there, and to be trying to do this alone.
Right. So on a medical side with doctors and healthcare professionals, how do we like where does it stand now? Because at one point where I was involved, with my mom had Alzheimer's and stuff like that. They weren't forthcoming with saying, "Oh, well, let's go take this test," because these things were happening, but they never said anything. They never initiated. How is it now? Is it that more doctors are initiating taking a basic test, or initiating saying, "Hey, you know what? This sounds like something else. Let me refer you to a social worker. Let me refer you to a neurologist." Like, is that happening now, or because people are going to go to their primary doctor, they're not going to know what specialist to go to or anything like that. Are
Right.
you initiating it now? Is there a push for doctors to do that? Is something happening?
I think there's more exposure both on the doctor side and the nursing side, and even other disciplines, as far as therapists, physician assistants, more exposure and more push towards people being in geriatrics and spending more time with older adults than there was before, and even in the classes, so both in the classes and in the clinical setting. So I will say that that is happening. So with that, I would see just more of an understanding to be able to say, hey, this is probably what's could be going on, or let me give you a test for this, or let me just refer you over to a geriatrician, for example, or a neurologist, for example. But that's not to say that just some of the gains that we've seen as far as that exposure is going to happen overnight. So I would still just also put it on over to the family member to advocate for, well, let me see a geriatrician, who they're going to be more of the experts in geriatric care, as opposed to a primary care provider, or let me see a neurologist. You might have to have a referral to a neurologist, but I would most definitely say a geriatrician. Um, yes.
Okay, okay. All right. So that's good. A lot most people they deal with their primary doctor for so long by the time they, get into their older age, they're so comfortable with them so
Right,
they don't want to change.
right.
And that's why
They don't want to change.
someone has to advocate for it or a doctor has to say, "Hey, this is the next step. It's okay." Because if they trust their doctor, they may trust who they refer them to as far as, the care, if they're getting older and there are things that are happening with them.
Exactly, exactly. And geriatricians are going to be more specialized in geriatric needs, than a primary care physician. So that's just something that we have to keep in mind. And it's not to say that you're leaving your primary care physician and you have to leave them, but it's just, more of a person working with a person that's more specialized in probably the care needs that you might have as you continue to grow older.
Right. Absolutely. Absolutely. Okay. So let's let me ask you about like for us just as far as the caregivers. You know, I know this professional caregivers and there are prepared caregivers for your family member is a caregiver or something like that. Um what would you say to them to be more what do they have to be able to keep their family member at home? Um, what would they need to do? Because it seems like some people feel like they can't do anything else, and that's the alternative is to send them to a nursing home, and sometimes they'll be in a nursing home for years. Is there a way? Is there some more things that they should know that they can do to keep their person at home as long as possible?
Yeah. I one thing I would say is to draw on supports I talked about earlier to engage with a social worker or engage with your area's agency on agency to understand what's available. Because a lot of times when we feel like there's no other option but to send our older adult to a nursing home, it's because there's so many hours that of care that's needed that that person cannot provide, or they're like, I don't even know what's going on, like if they have dementia, and it's like this is just hard. It's a lot of things that either it's a lack of knowledge, it's lack of resources, lots of lack of services. So really trying to have someone help with coordinating services such as a social worker or areas of agency on aging to help to identify what is available. So that's what I would say, because there could be Meals on Wheels, for example, or another meal services that they can bring meals to the individual, or transportation that can be supportive of taking them to appointments or different areas. If there's adult day centers or senior centers that the person could go to during the daytime that provides some respite for the family member, then that could be an opportunity that would be very supportive. And then supportive of the older adult person too, as far as getting up and getting out, because that really is also helpful with kind of just keeping someone going. And then just other supports when it comes to areas of agency on aging and a social worker, they can to see what the older adult person is eligible for as far as a home health aide and how many hours they're eligible for that. So if they can have someone come in the home, not even just a home health aide, but a homemaker that can help with cleaning up the house, where a lot of things that we've seen is just even the house, the state of the house can be very problematic, because doing things like laundry and vacuuming and all that kind of stuff can be very hard for someone to maintain their own home. So those kinds of services can be available. And then also home modifications. Biggest thing that ends up causing nursing home placements as well are falls, because someone falls, they go to the hospital, and the hospital says they can't take them back home. They can't send them back home, and they go to the nursing home. So if we could do an assessment of the home and do home modifications, whether there's grab bars or putting ramps or thinking about bigger hallways or lighting, those kinds of things that can be done in the home where in cases insurance will cover that. And those are things that we can do to kind of make it easier for the person to stay at home. But one of the things that ends up being the hardest is if there's not enough support as far as hours of care to support the older adult, especially if they need more hours of care. They need more, like 24 hours, 7 days a week. That gets a bit challenging. But if it's just something that, oh, they just need a couple of hours, or I need to go to work, don't sending them to an adult day center for the day can really help with that too. So I would just encourage one to look in, like there are resources and supports available. They vary based off of the community, but try seeing that and not try to feel like you have to do it all on your own, and see if there are enough services to kind of fit the gaps.
Okay. 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 Well, thank you. Thank you for this information. I really appreciate that. And, it's interesting how, there are so many people working on this, and I really appreciate the work that you do with this and research and things like that. And it's about people just knowing more and being more proactive and getting involved, and helping their family member, but really knowing different things that are out there for them to support, and what they can do, and be an advocate for their aging
Yeah.
parents.
Yes.
So, yeah.
Yes.
Thank you so much. I appreciate you giving me this information, and all the best. All the best on any other research that you may have.
Thank you so much, Francine. It's been great being on the podcast today.
Okay. All right. Thanks. Bye bye.